Good afternoon, and thank you for joining us for our PDPM Tips and Tools webinar. The presentation will begin momentarily, but first let's cover a few housekeeping items. This webinar is being recorded, so the slides and recording will be distributed via email. There will not be a live Q&A, but please feel free to submit any questions via email, and Kay can respond following the presentation. Her contact information will be provided on your screen at the end. The content of this presentation is to serve as a general resource and is being provided for informational purposes only. Our full disclaimer can be reviewed in the chat feature. Now, a little bit about our presenter. Kay Hashagen is a senior consultant with LW Consulting, Inc. with over 20 years of experience in healthcare and rehabilitation. She specializes in compliance, auditing, and performance improvement. Without further ado, I will hand it over to you, Kay. Thank you.
Thank you, Kelly. Let's get started. We have a lot to discuss. During this brief presentation, we're going to talk about the importance of accurate MDS coding and documentation under PDPM, and actually review some of the most common MDS errors that we identify under audit and provide tips on what you should be looking for. We'll discuss the expansion of PDPM from Medicare Part A to many of the long-term care Medicaid assessments, and we are going to review the reference tools that you should be using to code your accuracy, and also we'll talk about our PDPM rate chart. Well, PDPM started in October of 2019, so why would we need to discuss PDPM now? Because there really hasn't been many changes to the reimbursement model under Medicare Part A. However, it is amazing how many errors that we still find on audit. So we wanted to go over those for you, and also for those who maybe aren't familiar with PDPM, because it's now going to be part of the OBRA assessments. We wanted to go over that as well. I like to say that drips fill the bucket in PDPM. There are actually about 157 entries in the MDS that directly affect the reimbursement for PDPM. And to have accurate coding, you have to have all of those documented to support the coding. So there needs to be timely physician involvement, documentation that intervention actually occurred within that look back period timeframe. We want to make sure that what you're documenting is supported by the regulations in the RAI manual, and Chapter 8 of the Medicare Benefit Policy Manual really goes over all the technical requirements. And it is really critical to have that understanding of coding requirements and opportunities, because CMS gives you a lot of opportunities. There are gray areas where we find when we do audits that some companies are more aggressive, others are more conservative. The important thing is that you must have documentation to support your coding. Let's dive right into the technical requirements. I like to think that the technical requirements are the most critical one to make sure that you have systems in place so that you don't lose any money based on just mistakes with technical requirements. So the first thing is that you have to have a qualifying hospital stay, and we often see that if there are patients who have had a psychiatric hospital admission, they might not meet the criteria. So that is important to, if you have that type of patient population, to review the requirements that are clearly outlined in the Medicare Benefit Policy Manual, Chapter 8. Admission orders must be completed by a physician. An extender is not allowed to complete the admission orders. Check also if you have readmissions, because sometimes they are missed and they don't get written until a day or two later, and then those initial day might not be covered. Certification and recertification elements might not be patient specific. So remember, the elements include the reason for skill, also the length of stay, and the discharge destination. So you don't want to just have prefabricated elements, and they might change between the 14-day certification and your recertification. So make sure that you're reviewing them. That should be a good discussion during your Medicare meeting. And then also skilled services. You need to monitor them closely because they might not be supporting, especially if you have a longer length of stay. Often we see that nurses are documenting that therapy is the reason for the skill, and therapy might be involved. But when we dive in and we audit the therapy documentation, we might see that the actual frequency doesn't meet the requirement for skill, or the documentation doesn't support the medical necessity. So it's a good idea to have a great knowledge of what is your reason for skilled Medicare Part A. Sections C and D have similar focus areas. The BIMS, or your cognition assessment, is what is recorded in Section C, and the regulations say that the MDS must be signed on or before the ARD. So if your MDS is signed after the assessment reference date and there is no copy of the interview in the record, that would count as the MDS, the patient was cognitively intact, and it wouldn't be able to be scored correctly. Now, the BIM score, sometimes we see, doesn't support the rest of the medical record. So we want to think about the fact that if the whoever is scoring the BIMS finds that the patient has a cognitive impairment, which we know will add more reimbursement, if the nursing documentation and the IDT documentation is saying that the patient is cognitively intact, that's a mismatch. The other thing that's important to look at is the speech evaluation might be having different findings than the BIMS interview. Now, we know that the MDS requirement is the BIMS interview, and the speech therapist would use a different standardized assessment. But think about that. If there's a difference, maybe the BIMS was done at 9 o'clock in the morning and the patient is having cognitive issues and they're sundowning at 4 o'clock. So remember, that's where the interdisciplinary team can discuss this. And this is the gray areas that CMS gives you the opportunity to do your evaluations at the best time possible. So the mood interview is captured in Section D, and that's where we see depression. And again, the same thing falls true if your MDS is signed after the assessment reference date, then that would not be counted if you had a high score and you were getting that actual depression extra bump up in your reimbursement. And also the depression score might not support the narrative. You can see high scores, 10 to 12, and you aren't seeing that the patient looks like they're depressed during the documentation by the nurses. So that is something that can be reviewed during your meetings. And also, if you have a lot of patients that are scoring 10 to 12, I mean, we know that residents who live in long-term care often have depression, but if they are on the proper medication and they have good activities programs and other non-pharmacological interventions, we shouldn't see every patient having a score of 10 to 12. We know that CMS uses data mining, so if you have trends like that, that is something you want to be aware of. Moving on to Section GG, I kind of think this is a sneaky section because we seem to take it for granted, but honestly, we find a lot of room for inaccurate coding, and it can have a lot of impact on reimbursement. So most often we see underpayments on audits when there are widespread Section GG coding, and sometimes this is due to lack of knowledge. It is hard to do education with staffing these days, so we find that the most important thing to do is look at your tools. However, if you do have long-term care nurses who aren't familiar with Section GG, and they are still wanting to code based on Section G ADL coding, you might need to do some training on Section GG on the definitions and how to record properly. But the best example of a system tool is the use of an interdisciplinary tool to capture your proper usual Section GG coding. If your EMR doesn't have one and you are not using one, make sure you ask your representative, because most of the systems do have one. Sometimes it's just not turned on. If you don't have the availability, your RNAC can use a progress note and can document who is at the meeting and the dates of the assessment, and that can function as your usual scores. Remember that the scoring of 88, 7, or 9, which are coded as usual, will not give you the best reimbursement. So if there is documentation of even 1 or 2 times where therapy maybe has captured an actual functional score, that's what you should be coding. So make sure that you're checking that out. And then also, if the assessment period is not correct, it is a little bit confusing sometimes, especially because the interim payment assessment for those IPAs and the OBRA assessments is different than what you're used to for your 5-day assessments. And make sure that your scoring of the form, if you're using an interdisciplinary form, that it is clearly identifying the assessment range. Often it looks to us like you're using 4 days instead of 3, so make sure that that is clearly defined. Section I is where we code all of the diagnoses, and understanding the clinical uniqueness and the breadth of the primary diagnosis is really key in making sure you capture the best reimbursement that you can. So that primary diagnosis should be the reason that the resident comes to the SNF. And you want to ask yourself, why did they come here? Why didn't they just go home and get home health? Why didn't they go someplace else? So whatever you answer for that, that should track to your documentation to support that that would be the reason that you want to use for your primary diagnosis. And remember, that primary diagnosis for the SNF might be different than the reason they went to the hospital, because maybe whatever the initial diagnosis at the hospital is cleared up. Often we see things like encephalopathy or sepsis are cleared by the time they come to you. So you want to really look at that. And remember that there could be more than one diagnosis that meets the criteria for a primary diagnosis. And that's the opportunity that CMS gives you. When you look at the PDPM rate chart, you'll be able to see that you as a team want to make sure you pick the primary diagnosis that supports the reason for your skill and which will give you the best reimbursement. So the critical piece is, do you have the physician documentation and the documentation of interventions and skilled care? But always pick the one that gives you the best reimbursement that meets all that criteria. Other common errors or opportunities that we see in Section I, remember that septicemia and sepsis are different, and that's been a change recently. So if you have either of those diagnoses, make sure you go back and look at what's documented for symptoms and what kind of interventions you're using. I-4500 is for CVA, TIA, or stroke. And often we see that coded when the physician has actually only documented history of, and it's been 10 or 15 years prior. Now, if there is no active treatment, you cannot code that. But there is a reference in the RAI manual, an example that if you are giving prophylactic treatment for a history of a stroke and therapy might be involved, then you can code it. So that's where we like to say that RAI manual has great examples. Also remember I-4900 hemiplegia or hemiparesis. So maybe the I-4500 doesn't work, but I-4900 can give you the same reimbursement support for your hips coding. And you want to make sure that therapy is keyed in. If they're working with the patient, that they use that as one of their treatment codes and include any residual deficits in strength from one side to the next. Another one is seizure disorder, an I-5400. And of course, then that would need an ICD-10 code in I-8000. I never really thought that this was one that was controversial, but recently we did some audits and these patients were on a lot of psychotropic meds and they had seizure precautions. Well, it's very interesting when you go to the CMS mapping tool, which we'll talk about, and to look for the ICD-10 code. There's a lot of ICD-10 codes that relate to some type of seizure disorder or epilepsy, but really only one of them gives you an additional NTA point, and that one is included when there is intractable epilepticus. So just make sure that the documentation supports that it is intractable if you are coding that. Malnutrition or at risk for malnutrition, we've been monitoring for quite a few years, especially when the use of the mini assessment went into vogue. So that's okay to use that, but just make sure that you have physician documentation and that your care plan and MARS and TARS show that you have actual intervention during the look back period. Don't forget asthma and chronic lung disease. If you're coding I-6200, it's not just for COPD. And then morbid obesity is often a missed opportunity if we see that the physician did not document the morbid obesity. If you use your BMI and it shows that it meets the qualifications, and if the patient has comorbidities, you can get your physician to supplement that documentation and you can capture that for one additional NTA point. Some more coding errors that we want to talk about on I-8000 relating to this NTA classification. So the NTA, you know, is the non-therapy ancillary, and there are about 50 different categories in there that will give you additional reimbursement. And each code that you want to choose needs to have specific instructions. So I guess that the takeoff on this slide is that watch out for unspecified codes. They may not represent that a diagnosis is accurate for the resident, and we like to say that the NTA mapping tool is the place to go to make sure that you check to see if the diagnosis that you think you want to use is supported by the documentation and provides the NTA tool. All right, moving into J and K. Shortness of breath when lying flat in J1100C really is something that we have seen a lot of orders written for elevate the head of bed to prevent shortness of breath. And this is not going to count. You want to, if you don't have any instances of shortness of breath during the look back period, then it's not going to be present. So you want to make sure that you remember, if you just have that, you want to make sure that you, on your assessment, assess, does the patient have shortness of breath? Or remember, the REI manual does say that if the patient requests to have their head of bed elevated because of fear of air hunger, you can document that and it will count. Moving into section K, you know, sometimes we see the coding in for MDS and PDPM goes in and things go in and out of vogue. And this year we've seen more controversy and things going on with section K than we have in previous years. Sometimes we see that section K coding for swallowing doesn't include information from the speech evaluation. So verify that whoever enters your section K has the ability to review your speech coding, and sometimes they enter it on Tuesday and the speech evaluation is done on Thursday and there's misses. So that would be money left on the table. So make sure that whoever is doing section K entering into the MDS understands how to read the speech evaluations and also verifies them. On the flip side, I want to talk a little bit about oral residue, because oral residue does not necessarily mean residual food in the mouth. So when you look back at the REI manual and you look at the actual definition of things that will count for coding of K100 A B, section B, you want to make sure that if the speech evaluation just lists oral residue, but they don't have any other findings that would relate to like a muscle weakness or a signs and symptoms of aspiration, if they don't have any interventions in their plan of care related to oral residue, and the nurses don't have any documentation, I wouldn't code it. So it's important to make sure that your documentation is painting a picture of what's going on with this patient, and that's a great opportunity for your interdisciplinary team to discuss. The mechanical diet, you want to verify the order and make sure it's still active. And also, sometimes we see that every patient has a mechanical diet, so make sure that it's patient specific and required, that it's not using a mechanical diet because the patient can't cut it themselves. That doesn't count. The mechanical diet has to be related to the swallowing. And also for parenteral fluids, I think we all know that that comes from documentation that's supported from the hospital. So make sure that that's included in your medical record. Sometimes it's not uploaded timely to the EMR, so it's missing and it's not supported. And also just make sure that you're discussing the correct day to choose your assessment reference date so you can capture that hospital information. Moving on to sections M and O, I think the most important thing in M, skin and ulcer treatments, is that the documentation of 2 or more treatments can change the nursing category. So sometimes we see those checked off on the MDS, but we don't see any documentation that supports turn and position programs or hydration programs, etc. And section O has a lot of different things. Respiratory needs to be documented 7 days, at least 15 minutes. We often see oxygen that is documented by the nurses, but not captured on the MDS, and that can change your nursing category. Of course, IV medications are sometimes confused with IV hydration, so they're coded differently. Make sure you're looking to verify that and you don't miss any IV medications. Isolation is a big one because it really raises that nursing category, and there are 4 criteria that all must be met. Often we see there's no order, or it's not really isolation, it's more contact isolation. And sometimes we see that there's documentation in that doesn't show that the patient spent all of their treatment time in the room. We see the CNA ADL talking about walking in the hallway, or that the therapy notes say that they were in the gym. And then again, restorative programs are very important. If you're at those lower nursing levels, you need 2 programs, 15 minutes each for 6 days. And section Z is the last section, and this one doesn't happen very often, but it is important. You know, the REI manual requires an RN to sign the MDS in section Z, and that is the attestation of the accuracy of the MDS. And so if you, for some reason, your MDS populates signature as auto-populated, it doesn't have credentials or the actual signature, that is not going to count, and you could lose a full stay if you don't have that RN signature. Now let's quickly talk about the tools that we use to verify PDPM coding. The CMS website has some great options, and we're going to talk about them. The REI manual, the Medicare Benefit Policy Manual, and we're going to finish up with our rate tool. If you go onto the CMS website, you will see on that one page, and this is the link that will take you there, at the very almost bottom of the page, there is a PDPM presentation, and I'm sharing some of my favorite slides from that. I think it's 80 some slides, and it's tried and true. It's been there since 2019, but it really hasn't changed. So slide 25, I printed out those speech comorbidities. Sometimes I have to go back and take a look at them. Slide 27 is the PDPM cognitive measure classification. That can give you and your team a clear view of where the categories are for cognitively intact or whether there's any impairment. Slides 35 to 39 is a really great list of the 50 conditions and diagnoses that will give you points, and it shows on there also where on the MDS they're coded. And that is a great learning tool for your whole interdisciplinary team to make sure that you're not missing some of those. And also the administrative presumption classifiers on slide 73. We're not talking about those right now, but really, if this is a good one to remember. If you're concerned that maybe you don't have the skill and the patient did have a qualifying hospital stay, that you can maybe capture the days from the admission to your ARD. And that's the opportunity that CMS gives you for reimbursement. And then slide 89 is the nursing payment group to HIPS translation. There's no way you can remember which letter of the alphabet correlates to which nursing category in your HIPS coding. So I use this as a cross-reference. The next thing that we all use are the mapping tools. And so you can see when you open up the mapping tool, you go to the one that you is the year that you're looking at. And when it opens up, you will open up the Excel in your download. And at the bottom of that Excel file, you'll see clinical category, speech comorbidity, and your NTA comorbidity. So those are important to be able to verify that the codes that you think that you want to use are really ones that map and that are still accurate. The other thing that's on that website page is the PDPM FAQs, or frequently asked questions. And there's a lot of them, but this one we use often if the BIMS is scored. The date of the BIMS on the MDS is after the ARD. This is the CMS verification of why it tracks back to cognitively intact. So you can have somebody that has a pretty significant impairment of 2 or 3, and if that MDS is signed late and there's no copy of the interview, either staff or regular, there you're going to have it. You're going to be cognitively intact. And of course, the RAI manual is really our Bible for MDSs. I think it's important to remember to check the examples. I have section chapter 6 printed out because that's where all the nursing examples are. And of course, we always go to chapter 2 for assessment questions. Really, the best rule of thumb here is go to the RAI manual first before you ask someone or guess. The Medicare Benefit Policy Manual, chapter 8, gives you the SNF information. Chapter 15, therapy documentation. Make sure you use Control Find function to search and closely read the language. There is a lot of opportunity for interpretation in gray area. So here's our little internal tool that we have developed. All of our auditors use it, and we thought it would be a great opportunity to share it because we just updated it with all the new 2026 rates. So of course, this has it whited out, but if you purchase it, you'll be able to see all of the different rates. And why would you need something like this? Well, I like to say a picture paints 1,000 words. I love the fact that I can hold this in my hand, and I have mine printed out and laminated, and it's got bright colors, and it's really easy to see how the different categories relate to each other. And if your interdisciplinary team is trying to learn, or you're a novice and you want to know how those components impact the payment, I just think this is just really a super easy tool that you can have. You don't have to be jumping in and out of screens. You can hold it on your hand and you can see it, and it reinforces really the need of what you need to document and how impactful it is if you miss coding. So the first section is the PTO category, PT and OT category. thinking about PTO. The PT and OT category, which is really is the first character in your HIPS coding, and on the actual one, of course, there are 4 clinical categories, and then you'll be able to see the function scores that come from your section GG coding, and then that will show you your case mix, and then it'll then show you the rate. So you'll be able to see, say, remember that example I gave where you had choices for primary diagnoses? So you could see what the difference is, maybe other orthopedic works, and also you have clinical category, or you might have a medical management, and you can see what the difference of the rate would be if you chose one or the other. The same way as if you have a low function score, 0 to 5, and you're like, wow, if we started paying more attention, or therapy got in earlier and to do their evals, and maybe they could get a functional exam, you might be able to increase your rate for your PTOT category. Speech is the second one, and I think this is the biggest one to be aware of. And this shows that you have 2 buckets. The first bucket would be your presence of your acute neurological condition or any of those speech-related comorbidities. And you know, those, I showed you the slide that you can look at, and you can also go on the mapping tool to see if your diagnoses track to either of these. And then also your cognitive score for your BIMS rolls right into there. So you have 3 opportunities, either none, any 1, any 2, or any 3. So that's actually 4 opportunities for each one. And then the second category here is your mechanically altered diet or swallowing disorder. And those 2 go together. So if you have your section K coded, you can see you get neither, either, or both. And so that gives you from A all the way down to, I think it's K, that you would get a higher rate the more of those that you have. The nursing category on the actual PDPM tool is all on one page, so it's really easy to see all of the nursing categories. But for this example, you can see that the nursing component or category is listed on the left, and then all the different things that are involved. So it would be your function score, and that would also show you, like, say, for example, we were talking about isolation. If you had isolation, you would get an ES1. You'll be able to see the rate, where if you left out one of those requirements, how it would drop down. This is the second portion of the nursing category, the lower levels. So it's clinically complex, behavioral, and physical issues. So the depression and the number of the restorative services are involved in this section. So again, you know, you might think, oh, restorative, we can't do that, but it's the drips that fill the bucket. So if you have a lot of patients that are in that lower behavioral category or reduced physical functioning, you might really find that it's worthwhile to add your restorative programs in there. And the last HIPS character, the fourth one, is your NTA, non-therapy ancillary. And this is the biggest one because you know that this will increase your rate for the first 3 days. So there are opportunities for 0 to 12 points. And the more points you have, the higher your reimbursement is going to be. So make sure that you have physician documentation and that you're checking your mapping tool to make sure that you have captured everything you can. I like to look at this on the, if I'm at a 5 and I think, ooh, if I had 6, I could increase my rate by like $25 a day. Why, that's a good thing. So just like the old ADL bubble that we used to review, whether there was a B, or C for your ADL scores, I like to think on the NTAs. But if you don't know where the what your HIPS code is giving you, you might not even go looking. I mean, that doesn't mean to say that you should always have your documentation accurate, but sometimes we put more focus into things when we know. So knowledge is power. All right, so if you have any questions, as we said in the beginning, please email me. I'll respond to all of your questions. And if you are interested, you can download the rate chart. Here is our rate chart order information. It's very reasonable, and you will get the electronic version. You can do what I did, is print it out in color. You can print it on cardstock. You can have it laminated. You can do it for all of your people on your interdisciplinary team. Talk about it and see how it helps you to learn more about your HIPS coding and make sure that it's accurate. We do a lot of different things here at LWCI, so if you think that we have some questions, reach out to me and I'll look forward to chat with you. Thanks again for joining us for this webinar. Have a great day.